Hi, Assalamu alaikum and good morning everyone. Thank you for visiting my channel again. Abdurrahim here with you. So we are continuing our mitral regurgitation topic and I was explaining you about the parameters of mitral regurgitation. Today I'm going to explain some more parameters, but the parameters I explained you in the last 2-3 vlogs, they are the main parameters to quantify mitral regurgitation. Today we are going to discuss some more parameters or some more methods which help us to include or exclude severe mitral regurgitation. Okay, so I will go with the same pattern, that I will explain you the things and then I will show you few of them on my presentation, because rest of them are easy to understand. Okay, so I'm gonna start now. The first thing is regurgitant fraction. Okay, regurgitant fraction is very easy to measure, and if it's more than 50% regurgitant fraction, it means severe mitral regurgitation. Okay, there is no mild, moderate, severe criteria. Only if it's more than 50%, then you call it severe mitral regurgitation. How you are going to calculate it? You mainly need two things for it. One is the regurgitant volume of mitral regurgitation. The second thing is the stroke volume of mitral valve. So the formula will be the regurgitant volume of the mitral valve divided by stroke volume of the mitral valve. So you know the regurgitant volume, how you are going to calculate it, I explained you in the last vlog, and also the stroke volume of the mitral valve, I already explained you in the last vlog. So these two things you need it to calculate the fraction, to regurgitant fraction. So the formula will be regurgitant volume divided by stroke volume of mitral valve, or whichever valve you are going to use, multiply by 100. Once you will multiply with 100, it will give you the percentage. So if it's more than 50%, as I said, it's going to be severe mitral regurgitation. The second thing is, there is another way we use to calculate, to quantify mitral regurgitation, is jet area. Okay, regurgitant jet area size. So this is not a very good parameter to quantify mitral regurgitation. This parameter is good to to detect if there is mitral regurgitation or not. Okay, but to do this, like, you track the area and then you track the size of the LA and you say, oh, it's more than 40%, then it's significant. If it's less than that or more than 60%, don't use this parameter, because this parameter gives most of the time false information. Especially, for example, you are having an acute severe mitral regurgitation. In that case, you will have a small jet area with severe regurgitation. So if you will calculate the jet area, it would be small, but actually the regurgitation will be severe. Why the jet area is small? Because your LA volume is your LA pressures are very high, and also your blood pressure is very low. So you will have a small jet area, a small jet of mitral regurgitation with severe mitral regurgitation. Okay. The second thing is, in patients with high blood pressure or hypertension patient, they usually have a bigger jet area with the smaller actually mitral regurgitation. So you need to keep these things in your mind as well. Again, and in mitral valve prolapse or myxomatous leaflets, or maybe flail leaflet, you will see severe mitral regurgitation, but the jet will be very much eccentric, like wall hugging jet. So if you will calculate the area, it would be very small or small area, but actually the mitral regurgitation would be severe. So this, again, I will repeat that this is a good parameter to detect mitral regurgitation, but to quantify it, I would not go with that one. Okay, and it's not recommended as well. So this is the jet area. Another way to look for mitral regurgitation is look at the mitral E Doppler, the mitral Doppler, mitral inflow Doppler. So with the pressure increases, mitral E velocity increases as well, pressure and volume both. So as much as the mitral regurgitation gets severe, your E velocity start increasing. So if your E velocity in a native valve is more than 1.2 meter per second or centimeter per second, then you call it that this is severe mitral regurgitation. So 1.2, you need to keep this number in your mind. Okay, if it's more than 1.2, it's gonna be significant mitral regurgitation. Now, and then again, you need to keep this in mind as well, that this could be related to very severe diastolic dysfunction as well. You need to keep these things in mind as well, but this is another predictor. Then you come on to the pulmonary vein Doppler. It's a very important component. In transthoracic, we usually see the right upper pulmonary vein where we go and we do our Doppler. Okay, so you see it in the fourth chamber just beside the septum near to the right atrium. You put the color there and you see that the pulmonary vein is coming. You put the Doppler there. Usually you get three type of velocities. One is the S, one D, and then atrial reversal. So above the baseline you will have two velocities: S, systolic velocity, which will come in systole. Second one is diastolic velocity, which comes in diastole, and then the atrial reversal, which comes in after the atrial contraction. Okay, that comes below the baseline. Okay, so these are the three velocities you are going to see normally in pulmonary vein. But when there is severe mitral regurgitation, your systolic velocity, which usually comes above the baseline, gets reversed, and you will see systolic flow reversal, and that is a cause of severe mitral regurgitation. It means that mitral regurgitation jet is reaching till the pulmonary vein. Okay, so it's going into the pulmonary vein. Be careful once you are doing the Doppler of the pulmonary vein that you need to go inside the pulmonary vein. I don't remember the numbers. I think within 5 to 10, I think within 2 to 3 centimeters inside. I will see it and I'll show you on the presentation. So you need to go into the pulmonary vein Doppler to get this Doppler. If you're doing a TE, you need to try it. You should try all pulmonary veins to look at, because sometimes the jet is very eccentric and it's going into one pulmonary vein, but you are not seeing it into the other one because of its eccentricity. So try to Doppler all the pulmonary veins if you are doing a TOE. Okay. So this was the pulmonary vein Doppler. By the way, in some of the patients with severe mitral regurgitation, you can have systolic blunting as well. Like S wave, the first I told you that the systolic flow reversal, also the blunting, like your systolic wave is almost very small and very straight as well, and then you see the diastolic wave. So systolic flow blunting as also comes with the severe mitral regurgitation, but you need to keep in mind that you might see systolic blunting in severe diastolic dysfunction as well. So you need to keep these things in mind as well. And then definitely the next parameter is the dilatation of the left atrium. Yes, as much as the mitral regurgitation increases, the left atrium starts dilating as well. But left atrium start dilating. So left atrial dilatation is also very common with other diseases as well. For example, hypertension, for example, diastolic dysfunction, systolic dysfunction, also atrial fibrillation, rhythm changes. So these all issues can cause left atrial dilatation. So you need to keep an eye, like if you are saying that this is because of mitral regurgitation, then you should have other parameters to support. Okay, like these are the sportive parameters when I told you. So the next would be the left ventricular size and function. Left ventricle, in the later stages of mitral regurgitation, the left ventricle starts dilating, okay, and the systolic function gets impaired as well, but these are the very later stages. Okay, so these was the main parameters. I think I didn't forget anything, but if I forget, I'll let you know on the presentation. And now I'll show you a few of them on the presentation, just to understand like how I was explaining and how you will see it there. Okay, thank you. Let's come on to the presentation. Okay, here we are on to the presentation. I'm not going to take much time here because these are mostly the things were very easy and I explained you already. I'll just show you one or two things. One is the jet area, as I described you already. Jet area is good. Mitral, regurgitant jet area. It's good to detect mitral regurgitation, but it's not a good predictor for quantifying mitral regurgitation. So as I told you already, if you are having an acute mitral regurgitation, you will have a high LA pressure and also low blood pressure, which will have a small jet area with severe mitral regurgitation. And then in hypertensive patients, you can have a bigger jet area with smaller mitral regurgitation. So, and then jet area is also affected or dependent on mechanism of mitral regurgitation. If you are having a flail leaflet, so the jet will be quite wall-hugging jet, either anteriorly or posteriorly directed eccentric jets. So if you will calculate the jet area, it's going to be small, but actually the regurgitation is way more than that. So you will have severe mitral regurgitation with a smaller jet area size. In secondary mitral regurgitation, especially if you go into the two-chamber view, you will see a broader jet area, but the ERO is going to be small in those patients. So it's tough. You need to look at the other parameters as well to quantify mitral regurgitation in those patients. Okay, so this is one thing which I explained you earlier. Now I will show you about the pulmonary vein Doppler and mitral E velocity. So let's talk about the mitral Doppler first. Mitral Doppler also explains or also helps us to detect severe mitral regurgitation. Okay, and if your E velocity, as I told you, is more than 1.2 meter per second, it means there could be severe mitral regurgitation. But again, these velocities can be affected by a lot of other things, which I will explain later on. And if there is impaired relaxation like E to A reversal, it excludes severe mitral regurgitation. So if you are saying that you are doing a patient with severe mitral regurgitation and then you are having an impaired relaxation, it means there is something wrong. Okay, you need to look at your parameters, your regurgitation jet and everything again to look at maybe it's not very severe. So the next, which is very important point, is this one. The peak E velocity is also affected by even mild degrees of mitral stenosis in the presence of rheumatic disease, mitral annular calcification or mitral annular ring. So in these conditions, you should not try to use mitral E velocity. Okay, and these are again the same thing. What are the important points? Again the same thing, like if it's more than 1.2, it's going to be severe. If EA reversal, it's going to be not severe, exclude severe, and it's easy to do in TTE or TE both, and there are very less chances of error because once you're doing mitral valve Doppler, you are usually very much aligned in the four-chamber view, so there are very less chances of doing mistakes. So it's an easy way to do it, so we should look at it. Anyway, we are doing mitral inflow Doppler in almost every patient. Okay, so then you need to keep an eye on it as well. And it depends on LV relaxation and filling pressures. These are the important points which can affect E velocity. High E velocity not specific for severe MR. In secondary MR, when you are having a secondary MR, it doesn't, and you are having a high E velocity, it doesn't mean that it's severe MR, because in secondary MR you might have systolic dysfunction and then diastolic dysfunction, so it could be a combination of different things. So you should not rely on this one in secondary MR. And also atrial fibrillation and mitral inflow stenosis. So in these conditions, you should not rely on mitral E velocity. So the next thing is pulmonary vein Doppler. As I told you, like pulmonary vein Doppler, you are going to see three types of veins in three types of waves in pulmonary vein Doppler. One is systolic, one is diastolic, and one is atrial reversal. Okay, so as the regurgitation gets severe and the flow is going into the pulmonary vein, you are going to have this pattern, which is systolic flow reversal. You see, this is your systolic flow and it is reversed already, so it means this is severe mitral regurgitation. Okay, this is your diastolic flow. This is again systolic, which is systolic flow reversal. So you can mention it in your report that systolic flow reversal noted in pulmonary veins. Then this one is the systolic flow blunting. You see, systolic wave is very small and diastolic is very dominant. Okay, but in this condition you need to keep an eye that you need to look at other things as well, that this could be related to severe diastolic dysfunction as well. So once you are doing the pulmonary vein Doppler, you need a sample volume of 3 to 5 mm. You know that is equal to mark. Or the pulse wave Doppler sample size, you need to keep it 3 to 5 millimeter, placed 1 centimeter into the pulmonary vein. This is very important. I was thinking maybe it's 2 or 3, but it should be 1 centimeter inside the pulmonary vein. Okay, so this is very important point once you are doing this. So you see this one, this is the flow reversal here. Systolic flow reversal is more than one vein is specific for severe MR. Okay, normal pulmonary vein pattern suggests low LA pressure and hence non-severe MR. So this is another thing, like if you are saying severe MR and you are doing pulmonary vein Doppler and it's normal pattern, okay, it means there is something wrong. So it cannot be severe because the LA pressures are also normal, pulmonary veins, pulmonary flow is suggesting this, so it means it's not severe mitral regurgitation. So what are the pitfalls in this one? Eccentric MR of mild or moderate severity directed into a pulmonary vein alters flow pattern. So sometimes we have very much eccentric mitral regurgitation and it goes directly into one of the pulmonary veins. So if you are doing only that pulmonary vein Doppler, so you can mistakenly call severe, or maybe it's mild or moderate mitral regurgitation, but you call it severe because there is pulmonary vein reversal, flow reversal. So you need to keep an eye in especially in eccentric jets. Systolic blunting is not specific for significant MR, common in secondary MR and present in elevated LA pressure or atrial fibrillation. Okay, so these are, and atrial fibrillation also you can see it. So you should not rely on a pulmonary vein Doppler in this scenario. Okay, thank you very much. Hopefully I described everything. Regarding the LA and LV size, LA size, you can do the LA biplane size. It's easy, 4-chamber and 2-chamber size, and you can get the LA volume. Index, try to get the index. And then the LV size, you should do the biplane or triplane or 3D volumes to get the LV, EF and LV sizes, and you will know that what size of the LV and LA. LA will get dilated if there is severe mitral regurgitation, and LV will also start dilating if it's later stages in the severe mitral regurgitation. Thank you very much, and please keep subscribing and share it with others. Thank you. Bye bye.